Hello and welcome. Thank you so much for joining us. Today's webinar is titled Meeting People Where They Are, Harm Reduction Strategies in Supportive Housing. My name is Dr. Crystal Sosha. I'm a Senior Training and Consultation Specialist here at Rutgers in the School of Health Professions, Department of Psychiatric Rehabilitation and Counseling Professions. Thank you all for introducing yourselves in the chat. As we begin, we want to welcome you and remind you that today's webinar is hosted by DBHR through the Washington State Healthcare Authority. This is an interactive training, and we do encourage you to ask questions and participate throughout this session. You do have the option to respond in the chat as you see fit and as comfortable as you are. Again, thank you for letting us know where you are joining us from. Hoping the weather is beautiful over there in Washington. The sun is shining over here in New Jersey, and we're finally getting into sweater weather. So thank you for being here. A note about artificial intelligence. Please note that the use of automated note-taking bots or similar tools during Washington FCS events or meetings requires prior approval. Unauthorized use of such tools is prohibited to ensure the privacy and confidentiality of all attendees. Also, any recording that is created through AI is not recognized as an official recording of this session. We reserve the right to exit trainees from the training if they are using AI to take notes without prior approval or using AI to record the session. Please note that the materials and recordings will no longer be emailed to you. My colleague Emily Bands has placed a copy of the PDF into the chat, which was uploaded just now. Please note that this is our process moving forward, and so you will have access to that. There it is again. Thanks so much, Emily. A recording of today's session will be available on the HCA FCS channel on the YouTube approximately 2 weeks after the session. Again, thank you all for being here. Appreciate the check-ins. We're going to do another little check-in here. And I want to check in with you all to see where you are today. Before we dive in, I want to just check in with ourselves and with each other. One of the core principles of harm reduction really is meeting people where they are, and that includes ourselves. So which one best describes where you are at right now? I have a few options. Feel free to improvise if that is okay as well. A, calm and grounded. B, a little stressed but here. C, tired but curious. D, distracted or overwhelmed. E, open, unsure, but willing to learn. F, just doing the best I can today. Just doing a quick emotional check-in, recognizing sometimes we're energized. I'm seeing a mix of answers. Many of us are doing the best we can today. We're halfway through the week. Some of us might be feeling calm. Some of us are perhaps overwhelmed or distracted. Maybe a mix of some of the answers here. Kind of getting through that midweek slump. Appreciate you taking a moment to check in and maybe noticing where you're at throughout this presentation and maybe even at the conclusion of it, especially in the work that you do in supportive housing and how exhausting and overwhelming some of that work can be, and at the same time, how meaningful and impactful it can be. So thank you for letting me know where you are today. Excellent. Okay. And regardless of where you are, that's okay. We wanted to serve this moment as just a moment to check in before we begin. Again, this presentation is really centered around meeting you where you are and meeting people where they are. So today we are going to define harm reduction and explain its core principles. We'll take some time to identify practical harm reduction strategies applicable in supportive housing settings. So again, specifically tailored to you as our audience, if you are someone working in supportive housing. If not, we hope there are a few takeaways that you can still gather from today. We will take some time to explore how and what kind of communication techniques exist to effectively engage with individuals around substance use and related behaviors. And a lot of this is really learning how to engage respectfully and really in a trauma-informed way, which we'll talk about in just a moment. But some of these things are things that you can use on the day-to-day. And so we hope, again, that there is at least one takeaway for you all today. So again, we're going to keep things engaging and interactive. We're going to play a game. Is it harm reduction? So in the chat, I will ask, is it harm reduction? So in the chat, if you can answer yes, no, or if you don't know, that's okay. And we will go one by one and check in and see, is this, you'll see a box pop up and I'll read it aloud. Is it harm reduction? The first one, wearing a seatbelt. Lots of yeses, a few nos coming in. Many yeses. For those of you that said no, that's okay. Not a pop quiz by any means. When we think about wearing a seatbelt, yes, it is harm reduction. It reduces harm in case of an accident. In some ways, you're also, if you think about if you've ever been in a Psychology 101 course, maybe quite some time ago, or have learned about positive and negative reinforcement is really resolving that dinging sound as you get into the car. And some cars these days now do a little buzzing or dinging noise. So clicking that in is a reminder. What about the next one? Using sunscreen at the beach on a hot day. Yeah, lots of yeses. Absolutely. Protecting against sunburn. All right. What about quitting cold turkey after years of smoking? Here's where we get a few mixed answers. Maybe yes, no, no. And this is almost like a controversial one because there's some harm reductionists who say it's not necessarily harm reduction, it's more of an abstinence-based strategy, and abstinence could be harm reduction as well. So that is a bit of a tricky one. What about using nicotine patches instead of smoking? Back to all the yeses, yeah. And absolutely, abstinence is a harm reduction if that's the person's goal. Harm reduction isn't a thing, it's an approach, exactly. We'll talk a little bit about what it is within that approach. See, no yeses, yes and no. Depends, yeah, and really what we're doing here could be reducing some level of risk. What about drinking water between cocktails at a party? Is that harm reduction? Yes, kind of. Again, similar to the last one, if we are lowering or reducing risk, yes, it is harm reduction. What about a zero tolerance substance use policy in housing? Is that harm reduction? Yes, I do agree. I see the comment about depends on the person's goal. I'm seeing Lots of no's as well. Yeah, I think, and we'll talk a little bit. I'm kind of using this as an activity to get into what really is harm reduction, but seeing where we are all at, it all does come down to exactly that client choice, client goal, really using that person-centered approach. What's harm reduction for one person might not be for another, could actually be increasing risk. And what about the last one? Providing clean needles to help people who inject substances. Right, maybe a more classic example of harm reduction. And giving these examples in a way to really recognize harm reduction is a part of the human experience. We probably all have engaged in putting on a seatbelt. We've probably engaged in putting on sunscreen. So whether it's one of those or whether it's about, keeping naloxone on hand or using one of these other strategies, harm reduction is really about recognizing risk and reducing it without judgment and without imposing our values. It is often practical, person-centered, and ultimately about respecting a person's rights, their wants, their needs, and allowing them to make informed choices. Yeah, absolutely. We're going to get into that point as well. So, if you all could define harm reduction in your own words, how might you define that? What exactly is harm reduction? Non-judgmental supportive care to make safe progress, providing a safer method, any positive change as defined by the person making the change, belief in the person, minimizing negative consequences with lots of responses coming in, client choosing what that means to them, helping them find their potential, making small steps based on an individual's goals, providing safer means to reduce their current risk of whatever their situation may be. Harm reduction is any strategy to increase safety while engaging in risky behavior. Anything that minimizes risk. Ooh, I like that. A philosophy and practice of community care which seeks to help keep each other safe from quote unquote high risk activities. Any action, policy, process that seeks to minimize harm, improve outcomes, centers the person and their choices, making the change first, getting people the information to reduce harm. Yeah, sometimes it is about sharing and providing information. Depending on the person, taking action that can minimize risks, whatever that may be. Not necessarily eliminating a behavior, but choosing a safer alternative. And that's such a good point, and this is actually true even beyond harm reduction. If we are taking away something from someone, they're likely losing something or removing something. We always have to add a replacement behavior. It is not as simple as simply taking something from someone without any kind of skills to give them back. Creating safe investments, supporting in minimizing the negative health impacts, judgment-free, recognizing people deserve dignity and respect. Yeah, absolutely. So the National Harm Reduction Coalition really combines all of these pieces. Oh, there's so many good examples. Acknowledging that there is no one right way to recover. Yeah, all the complexities. So the National Harm Reduction Coalition defines harm reduction as a set of practical strategies and ideas aimed at reducing negative consequences associated with substance use. In a larger scale, or zooming out a little bit, it really is a movement for social justice built on a belief in and a respect for the rights of people who use substances. So harm reduction really isn't about whether someone uses or stop uses substances. It's really about reducing harm and improving quality of life. It is very much based, I saw examples of dignity, respect, compassion, empathy, using evidence-based strategies instead of punishing or placing moral judgment or blame on this person. Harm reduction also recognizes and does not attempt to ignore or minimize the real and tragic harm and danger associated with substance use. At the same time, it directly addresses them to reduce that effect. And so we know sometimes supportive housing programs, and think of any program, may require or demand total abstinence. And oftentimes that actually does more harm. And so harm reduction really is about the belief that people can and always will be engaged in working to improve themselves and their circumstances. And each time someone walks in your door is an opportunity and a recognition and a sign that they are motivated to seek help. Okay. So some of us really have also highlighted some of these principles, and I kind of summarized them in a few key points here. Harm reduction, again, really through the National Harm Reduction Coalition, outlines some of these principles, including accepting that substance use is part of our world. Harm reduction doesn't just pretend that substances and substance use doesn't happen. Instead, it focuses on reducing harm rather than ignoring, condemning, or criminalizing use. And that's kind of its larger function. It also prioritizes improving quality of life, not simply decreasing use. And success isn't necessarily measured by abstinence alone. So goals, like we've talked about, might include safer use, reduced risks, improved health, better housing, increased social connections. It also emphasizes non-judgmental support through non-coercive services. And so a lot of the work that we do, again, is meeting people where they are. As housing staff, we often support without shame or force and recognize that our supportive nature and some of the engagement strategies that we use help individuals to change. And so again, it doesn't necessarily require sobriety or abstinence or meeting these really quote strict conditions. A lot of harm reduction also leans on evidence-based person-centered practices and really supports people who use substances in reducing harm, affirming that people who use substances also have a voice and really should be integrated in policies, practices, procedures, and at the center of decision making. It empowers communities and individuals. And again, really, harm reduction comes from a compassionate, practical, and person-centered place. All we are doing is really supporting people in respecting autonomy, supporting positive change without judgment. And so I invite you to lean in to that today, and to be curious about some of the things that we may already believe. Maybe this is an affirmation for some of us. Maybe this is a new takeaway today. Harm reduction, of course, is not new. And sometimes there are some challenging or opposing opinions to harm reduction, especially in supportive housing agencies or nonprofit organizations or treatment centers. Each agency and body functions differently. So it's definitely not a one size fits all to many of our points here today. It really depends on supporting this person and having them make an informed decision about their future. So, I'm gonna go through a few myths and some of, I mean, just two myths, but maybe some of the more common ones. But I'd like to hear from you all, what are some of the myths that you hear about harm reduction? Enabling, that's the biggest one. The word enabling just drives me nuts. Yeah, that is actually some of my first one. Yeah, it only encourages them. You're just letting them use. They're still getting high, so how are you helping them? And that is really, I mean, one of the biggest myths to exist. Um, and some of the reality or truth behind this is that you are really helping a person stay connected and stay alive. And so harm reduction does accept that people will engage in risky behaviors and coming from a non-judgmental place doesn't mean that those decisions are encouraged. And it acknowledges, again, these very real harms associated with these behaviors, but again, doesn't contribute to this idea of, quote, enabling. The other one that we hear quite often, and some of you have shared, harm reduction is the same as giving up. Or, it really is, maybe not caring anymore. And the community matters. I see the comments like, yeah, maybe your town is small and closed-minded. And so many good points around like your risk is probably much higher if we have to hide. I mean, and that's true for really any behavior. Think about behaviors that happen behind closed doors because of stigmatizing issues and the stigma behind substance use or addiction or any behavior. And so the reality of that is that it's actually a doorway to trust and care. And so again, harm reduction's main goal is to keep people alive, as we just said, help people stay connected with recovery resources, provide information, share information, um, kind of roll alongside or almost co-pilot with this person in their journey, guide them or work with them, and recognize that everyone absolutely has a different recovery journey. And so everyone has a different reason for engaging with substances. And a lot of the work that we do is providing people with the tools to choose less harmful ways of engaging with some of these risky behaviors. I see an analogy, so I'm gonna read that one aloud. So appreciate some examples that are being shared, and apologies that I can't get to every comment. I see strict parents, the analogy of strict parents raise sneaky kids. When folks are constantly shoved behind doors and just told no, they will continue on a more challenging upward battle without the support of their community. Yeah. So recognizing that and think about many of the people that you're working with have probably been raised or grew up in an invalidating home environment and how that impacts a person's emotional health, physical health, how they engage with others. Think about your classic nature versus nurture, the impact of environment and genetics on a person's overall life and decision making. If someone perhaps struggles or has never been taught how to regulate emotions, think about how that um, plays a role. Give me just a moment. Right. So, checking in with you all. You know what? I'm going to actually move to our next slide. But more questions to follow, and thank you for your engagement. Um, it is important to also recognize that there is a spectrum of use, and substance use is often best understood on a continuum. And these continuums have existed in so many different ways, depending on the theoretical framework or orientation. But if we really look at our spectrum, we want to recognize the range of behaviors, the intensity, the frequency, the impact on a person, how people engage with substances in so many different ways. And it's, again, not a one size fits all. And we recognize that harm can arise at any point along this continuum, and interventions can be really tailored at any point across this continuum. And so on the next slide, I'll share some examples of interventions for each stage of substance use. So think about someone who perhaps is not using or engaging in abstinence practices, maybe the complete non-use of substances. Often some of the goals in many traditional treatment models, but again, not always a starting point for someone and oftentimes not recommended. But recognizing that abstinence can be a personal choice for someone and really aligning with their decision and autonomy is important. Then we have experimental, occasional, or situational use. Think about infrequent or sporadic use, or in social settings, or with peers, in special occasions, or on holidays. Typically low risk for harm, but of course could always have a potential for escalation. At-risk use, so that might include something that might look like someone who is engaging in binge drinking behaviors over the weekend, but maybe it's just on Saturday, or someone who says they only, drink one day of the week, or someone who might be engaging in substance use in unsafe environments. So there's some potential for risk and might result in maybe physiological, psychological, or social consequences if continued. And so a lot of our early intervention really is to focus on that harm reduction, education, motivational support. Then there's problematic use or patterns of use resulting in negative consequences, which think about how this impacts people where they live, learn, work, play, worship. So it might affect relationships, employment, physical, mental health. Perhaps maybe doesn't necessarily meet full criteria for a substance use disorder. But again, lots of indicators that there could be signs for interventions. And then the substance use disorder. So based on our DSM-5 criteria, ranging from mild, moderate to severe, and recognizing that this perhaps might require some additional structured treatment. So keeping these layers in mind as we move forward. Sometimes it's helpful to also notice how each stage of substance use has a corresponding intervention. And again, also think about this in terms of stages of change too. And that can be reflected. I share that on the next slide. When someone is perhaps not using or engaging in abstinence, we might provide psychoeducation on relapse prevention. We might promote additional skills. We might kind of just continue to build rapport and build a relationship with this person. For someone who maybe is engaging in experimental, occasional, or situational use, a lot of this is where we think about someone who might be open to hearing new information, perhaps. So we're sharing information about safer use. We are continuing to approach in a non-judgmental way. We are using compassion and empathy instead of saying, and I'll give some examples in a little bit too, but instead of saying something like, smoking is bad for you, right? Exploring like, hey, I wonder what you know about this. Insert substance behavior and being curious about that. At-risk use, if possible, we might teach safer use techniques. We might encourage regular health checkups with primary care providers. We might be supporting them in, again, some additional education or motivational support. As we get further along the continuum, that is really where some of our motivational interviewing skills really come into play. So we are focusing on skills-based strategies. Of course, a lot of this is ensuring that this person is ready and willing to make a change. But again, taking it as if someone is in your space and if you are paying witness to their story, there is likely some level of motivation for this person to change. And at the same time, recognizing that a lot of the work that we do really is in some ways connected to grief. There is often a big loss that's happening here. And then again, for those who may, um, let's say, qualify or meet criteria for a substance use disorder, again, we might continue to really revisit that same strategy as the beginning, providing relapse prevention, assisting with some of the social determinants of health. What are some ways that we can reduce harm beyond substance use? Maybe there's ways to reduce harm in terms of housing or physical health or mental health. Supporting access to medication-assisted treatment, providing overdose prevention education. All of these things can be quite helpful, again, regardless of where someone is at in the spectrum, to support them in providing them with new information. When we're providing information, I may be jumping ahead, so I'm going to hold that thought actually. I want to take a moment to talk about the stages of change. Like I said, each intervention can be important to be targeted at a person's stage of change and not only their level or frequency or intensity of use, but sometimes it's important to recognize where they're at in their stages of change. So, when are people ready to make a change? What does that look like? How do you know when someone's ready to make a change? When they decide they are. Yeah. When they get tired of their current circumstances, they talk about it. Absolutely different for each person. They say they are. Maybe they're literally vocalizing or verbalizing to you, I'm ready to make this change. Asking for help, seeking resources, change talk. And no one can be forced into changing themselves. They must make the choice on their own, absolutely. And that really goes back to some of our principles. As supportive housing staff and as just helping professionals, our goal is never to coerce someone or to force someone into making a change that perhaps we might think is good for them, or it might be in our best interest if they did this thing. But we want to let some of that go as we are supporting them and really meeting them where they are. General curiosity, they express change talk, yeah. And so people really become or they change or want to change voluntarily when they're interested in or concerned about the need for change or this behavior, when they become convinced that the change is perhaps in their best interests or will benefit more than it'll cost them. Maybe they're taking a plan of action and really working on being curious about that change. So think about, again, all of the stages of change. You might already be familiar with this. And so we'll look at exactly how this sounds for someone who may be engaging in substances. So someone in the pre-contemplation stage might be saying things like, I don't have a problem, or they might not see a value in change. They might not um, be thinking about a change. They might not recognize any need for change. And a lot of this is really where some of our foundational relationship building skills come in. We're supporting this person in, um, we're engaging in dialogue and discussion, showing that we will continue to show up for them. In contemplation, maybe this person is telling you, I think I have a problem and I'm not sure if I want to change. And so this person is really weighing out the pros and cons, the benefits and the barriers to change. Sometimes people say harm reduction really starts here. Like, okay, this person is already exploring the possibilities. So there could be ways to see how to reduce the risk of their current behavior. In preparation, someone's saying, I'd like to change soon. I'm thinking about it, but I just need some help with how to begin. And so maybe this person has already weighed out the pros and cons. They've identified some benefits to making this change, and they just need some support from you in order to begin. Maybe they're thinking, I really want to attend a local recovery support meeting. But, I'm not sure where they are or how to get there. And I don't really know who to go with, and I don't really have any friends right now. And people don't really connect with me, but I know that I really want to see what it's about. And so helping them maybe with identifying resources. Again, a lot of our role is sharing information. Action, this person is actively making changes. They are needing your support and continuing to change. So individuals who might be using harm reduction strategies. Maybe we are providing some skills, we are exploring safer methods, we are reducing the risk. And all of this really is an all-consuming activity. And then in maintenance, so maybe this person has made some changes, needs some help staying this way. And again, maintenance doesn't necessarily mean abstinence or sobriety. It means whatever this change is for this person. And so we know that people will oftentimes, quote, recycle through many of these stages of change before change becomes fully established. And so thinking about, someone who smokes tobacco often tends to cycle even 3 to 6 times at the minimum through these stages. And think about even for yourself, a New Year's resolution or starting a change for the first time and maybe some of the challenges in continuing that change. So keep some of these things in mind as you are supporting someone and maybe exploring new ways to identify how to show up for someone using a harm reduction approach. One of the biggest things as well is exploring where improvements can be made along this journey. And so there is a foundational theory originally coined by psychiatrist Norman Zinberg, which was called drug set setting. Is anyone familiar with drug set setting as a theory for understanding substance use? It's also changed over time. I like how the National Harm Reduction Coalition talks about it in terms of risk setting. Ooh, some of us know. Please tell, stay tuned. For those of you who know a little bit about it, feel free to share in the chat. So when we are helping someone to really, again, understand their use, this model was really created in identifying how these components shape a person's experience with substances, as well as the potential harms that might unfold. So the first part is identifying the risk. What is our issue being presented? What is the substance this person is taking? How is it being taken? What is the effect of the substance? What is the possible risk for overdose? What are other possible sources of harm that might be connected to this substance? Yeah, amazing. Thank you for that. I think I don't, correct me if I'm wrong, Emily? Emily? I see exactly laid out some of these pieces. And so, Emily, okay, thank you. So when we're looking at the risk, again, identifying the substance, how it's taken, is it injected, smoked, swallowed, the dosage, the potency, the duration, some of thinking about those harm reduction strategies that we can support with this person. Maybe there's education about safer risk or safer routes of administration. Maybe there's overdose prevention tools like naloxone. Maybe there's safer use kits depending on the substance. The next piece is set, so the individual's mindset, as well as physical health, yes. How are they feeling? Who is this person? Are they confident, angry, anxious? Are they physically in pain, hurt? What do they need to get well? Can they engage with you fully? Are their basic needs being met? And so the set really refers to this person's mindset or internal state, their mood. Think about trauma history, we've already mentioned just a little bit, maybe personality, past experiences, genetics, environment, setting. Even think about the location of your supportive housing settings. Depending on where someone is it next to the local liquor store? Is it next to the vape shop? Where is this person in their environment and what is their mindset around the substance? And then setting. So where and when that substance is used. So again, keeping some of those pieces in mind, like what is that physical environment where the potential harm is occurring? At home, at work, on the street, who's around them? Are they close to any police, bystanders, other individuals? How does this person present to people? How do they react? So thinking about some of the where and when of that substance use, the physical, the social, the cultural context, social dynamics. Is this person alone, with friends, under supervision, with family? Is there any like perhaps legal context or something like fear of arrest or criminalization? And then any stressors, whether that's environmental, whether that's personal stress. Think about this person's things that are happening in their life. Maybe this person has a history of being unhoused for quite some time or is at risk for violence. And does this person have a social support network? So really identifying some of these pieces and helping this person to ultimately achieve harm reduction in a way that works for them. Because if we don't know these key pieces, and if we're only focusing on eliminating the substance use or reducing the substance use, then we are missing some of these pieces. And so if we can start by improving some of these layers, we might be able to support this person in seeing them as a human and not only their substance. And so I say this with um, the idea that this is so important, and of course it matters, and it can be so hard for someone to think about changing their substance use when they're hungry, when they're in pain. I mean, think about how many individuals you're working with that maybe haven't seen a dentist in quite some time, and they've got a horrible toothache, and the toothache is now infecting a migraine or infecting their overall physical health, or maybe they've got a co-occurring disorder. Yeah, maybe there's other mental health conditions. Maybe this person, again, doesn't have stable housing or any social support. So it is so important to really kind of go through this as your own personal assessment and making sure that you are capturing this person in their entirety. Additionally, we talk about common harm reduction strategies, and we've really taken some time to cover a few. But what are some of the most common harm reduction strategies that you all use? Of course, I know that it depends on the person and who you're working with, but tell me a little bit about some examples or practical strategies that you've applied in your work with individuals? Safety plans, don't use alone. Yeah, the buddy system goes a long way. Methadone program, supplying Narcan. Maybe connecting with staff or calling the site. Using clean supplies. Reducing from hard liquor to beer or wine. Supplying Narcan. And I know, I believe I did add a resource to the end, but there's so many places and organizations that do provide free Narcan kits with training provided as well. Getting someone into housing, he was using meth to stay awake on the street, and once he was housed, he was able to dial back his drug use considerably. You think about our basic needs. If we don't have our basic needs met, it can be so hard to think about anything else or to function effectively in any other way. Listen, to have them heard, feel valued. Transportation to needle exchange programs, test strips, measuring tool for alcohol use, brainstorming ideas and empowering personal choices, creating a treatment plan together. And I love that idea of collaboration because that is really the core of the work that we do. So we've covered a few of these here, and I will just share all of them. Again, providing clean supplies or safe disposal options, having availability to naloxone, the access to it, and the training on how to administer for staff, as well as for individuals you're working with, providing safer use education, as well as supplies if possible, or connection to the resources that provide the supplies, having de-escalation and overdose response training as staff. Thank you for the resources. Flexible policies that reduce eviction due to use. And that is such a big challenge. Sometimes we know that we might be working with landlords who have very strict guidelines around substance use and what that means. Thank you so much for that. Clean environments, medication-assisted treatment, peer support, and motivational interviewing. What are some of the perhaps current policies that exist for you all in terms of supportive housing agencies? And maybe some of the challenges that you've experienced in terms of policies and this idea of if someone engages in use of any kind, they're at risk for eviction. What are some of those current policies that you're navigating? Smoking inside the unit. What else? I see a prior employer only allowed people in the shelter if they could pass a urine analysis. If they failed once, they were living there, they were kicked out. Yeah, I mean, what a difficult and strict policy. This person is actively seeking shelter and has the requirement to complete the UAs. Yeah. And again, that poses such a barrier to this person's ability to have housing stability, to achieve larger goals, to prioritize their safety. And so we recognize some of those challenges, specifically when trying to apply harm reduction. Sometimes harm reduction really is, again, the approach of providing and sharing information about a specific substance. Education goes such a long way. When I think about sharing information, I often think about using an ask, tell, ask approach. So ask this person, what do they already know about whatever you're about to tell them? Are they interested in learning about this? Have they heard about this? Coming from a place of curiosity. So that's our ask. Then tell them about it. So here's a little information about X, Y, and Z substance. Here's a little information about safer practices. And then ask them the last part, the final ask. What do they think about that? How does that land for them? Any questions that might be coming up for them? Does that seem like a reasonable thing to hear or do? So I say this with sharing information is not simply about information dumping, but if we could take a moment to pause and use an ask, tell, ask approach, almost allowing this person to consent to this information receiving from us rather than just dumping, it could be a way to, again, build that relationship and share some harm reduction strategies. Access to those tools, supplies, clean syringes, naloxone, support. So offering services with maybe minimal requirements for participation, recognizing the challenges that if someone needs to complete a urine analysis, or if someone has to maintain sobriety for X amount of weeks, months, days in order to live there, that is going to pose a serious barrier to this person in achieving their goals. And then linkages. A lot of what we do is connections to other services, healthcare, additional mental health resources, HIV or Hep C testing, treatment, facilitating access to maybe an intensive outpatient program or partial care program when this person is expressing interest and desire. And so using all of these four to work together. And absolutely, some counties and locations have their own requirements on, unfortunately, abstinence-based policies, and that poses a huge barrier. So again, I say this not to be so redundant, but thinking about how housing can be accessible without strict requirements, like sobriety or treatment adherence, and really focusing on how can we minimize entry barriers. Like you don't need to necessarily, quote, be ready to be housed. If someone is coming to your door and seeking shelter and looking for housing, helping this person to reduce the risk of their behaviors can follow if they're able to be housed. So think about that housing first or recovery model, recognizing some of the challenges and changes in what this looks like across the nation, and doing our best to really prioritize that immediate access to housing without the requirement of abstinence, sobriety, or participation in services. Does anyone's agency or organization strongly recommend or it's mandatory to be involved in like any kind of higher level of care treatment, like a group or a program? Is that a requirement of your agency? Not some of us. Awesome. See, some of our folks come from crisis stabilization or therapeutic specialty courts. Some of us don't require any involvement in treatment to get assistance. Great. So again, recognizing that if we can improve housing retention, we can likely reduce hospitalizations, incarcerations, risky behavior. And yeah, sometimes it might not necessarily be a requirement. Really using non-punitive responses to use. Again, the goal is not to evict someone after using, not penalizing them in any way. Being able to respond to a person's substance use with support, and again, harm reduction rather than punishment. By doing that, we're able to keep people engaged and safe. And then, of course, making sure that staff is trained on de-escalation strategies in the event that there is a conflict, being able to confront conflict calmly and avoid confrontation, especially during a crisis, being able to use trauma-informed, culturally responsive communication strategies, meeting this person again where they're at, and to prevent escalation and maintain this person's safety. So I will take a moment to share just a short video for those of us who maybe aren't quite believers just yet. Or maybe for those of us who are, I hope this is affirming. But this is from our National Harm Reduction Coalition. I'll just share a bit of it, maybe pause in the middle. That really speaks about harm reduction and its truth coming from individuals who have experienced its approach.
You ready?
Personally, for me, harm reduction is important because I watched my brother use drugs for years and ultimately overdose and die.
Harm reduction is important to me because it means keeping my family safe.
I believe that it also includes therapeutic rather than punitive drug policies.
I have a lot of family drug use, and it was constant fights, bitterness, anger.
I was lucky enough to make it when I had some times of struggle.
In my world, I believe to change someone else's life is to change their narrative.
And with harm reduction, I've learned not to have all that anger, to be more compassionate, to not judge anybody and be so critical.
Harm reduction gave me a sense of family, sense of belonging, you know, a place where I was accepted just as I was, just as I am.
As a physician, I believe in harm reduction because I'm sick and tired of my patients having to die.
I lost my daughter to the disease of addiction.
May all beings be free, and may my work contribute to that freedom.
It's important for you to find your own healing, to find your own path.
It's about civil rights, it's about public health.
Helping people regardless of the choices they make in life.
We don't judge people.
I believe that the people themselves are the experts on their own lives.
My harm reduction truth is that I was a skeptic, and even as a person who injected drugs.
I believe that harm reduction
is a movement that is never going to stop.
That advocates for human rights, that advocates for humanity, that advocates for being a whole human being and respect.
Harm reduction works because it was created for and by people who use drugs.
It's not a radical idea. None of these concepts that people are complaining about and think are radical. They're life-saving, common sense things.
I believe that harm reduction is the absolute opposite of tough love.
Harm reduction asks us to look at people as full human beings and recognize their full humanity, and that is challenging because we live within systems and structures that every day require us to do the contrary, to stigmatize and to dehumanize people.
When I was looking to build a relationship with my father, there were so many people who told me to forget about it, to wait, and for me, I lost the opportunity.
My boy Kenny, he was only 25 years old, died of an overdose. He was a peer educator just like me.
The truth about harm reduction is that the bigger our movement grows, we run the risk of losing the essence of harm reduction.
My truth about harm reduction is that it is the answer to most of life's problems. The hard part about having that skill in knowing that that's true is actually doing it.
Yeah, I believe that people really do want to be healthy and well.
I believe the war on drugs is a war on people.
Harm reduction has helped me reunite with my family and most importantly with myself.
Harm reduction is part of my life. Harm reduction saved me.
I believe harm reduction is just another way of saying that I care about you.
In my mind, harm reduction is the real thing, and that is love. And that's what I try to do each time I step on the street, to deal in love and safety.
I feel like our community has been so stigmatized and pushed down and pushed out and pushed away that people forget that we're not even just like them, we are them. You know, we are people. We are your neighbor, we are your son, we are your friend from college.
Harm reduction is rehumanizing. Harm reduction is love. Harm reduction is kindness. Harm reduction is helping. Harm reduction isn't about me. It's not just about you. It's about us.
Okay, I couldn't help but play the whole thing naturally. Any takeaways or things that we noticed about the harm reduction and its truth? What came up for us? Much more of the human aspect of it, yeah. Really seeing the whole person. Yeah, harm reduction is us. It's not about condoning drug use, it's understanding the dynamics, the technique of being person-centered. Each found harm reduction was positive and personal. Yes, I'm a big advocate for lived experiences. And so I love hearing from voices of individuals. And we need more of that. Harm reduction means I care about you. Yeah. I know that was pulling at my heartstrings, really. But I hope that this was a important takeaway. We're not like you, we are you. Yeah. I love the part about describing it as it as caring about you. Harm reduction is about helping people where they're at, not trying to fix them. Thank you for that recommendation. And yes, I could do a whole nother presentation about the history and its harm and the war on drugs, and as a whole, so much context to the history of it. Okay, so really emphasizing the benefits of harm reduction. Not only does harm reduction support a person and who they are, but it also supports their health. It supports them in preventing overdose. It supports them in improving access to healthcare and appropriate testing, mental health support, reducing stigma, and again encourages housing retention and sees stable housing as a foundation to long-term recovery. And so we know again that many of the individuals we are working with in supportive housing have experienced probably complex layers of trauma. And so trauma-informed care often overlaps with our harm reduction approach. Harm reduction is most effective when it is trauma-informed. And so this means really seeing behaviors in context and being mindful about how power, rules, and control can re-trigger trauma. Being able to recognize trauma responses, behaviors like withdrawal or irritability, frustration, maybe shutdown, distrust may be trauma responses. It's not someone trying to be difficult or, quote, manipulative. And so learning to identify some of those signs of trauma-related stress and avoid reacting punitively. Stay curious. I think curiosity just goes such a long way. We can continue to be curious about almost everything in life, and I think curiosity often comes from a compassionate place. Creating emotional and physical safety, making the environment feel predictable. Every Tuesday at 2 o'clock, I'm going to meet with you at your house, and we're going to take some time to talk and work on your goals. And I'm going to be here for you. And I know that you've, been with us for quite some time, and I'm going to continue to show up for you and support you. Building trust through some of that consistency. always assuming that trauma is present. So really taking a universal precautions approach, assuming that every person you encounter in your supportive housing agency or practice has likely experienced some form of trauma, and really being mindful of practices that could even unintentionally re-trigger trauma. For example, your physical closeness, cornering someone, loud voices, sudden changes, and really being able to build policies around safety and sensitivity. Again, this is kind of our running theme, avoiding coercive or punitive responses, and ultimately empowering choice and control. Even small choices can help someone build autonomy, rebuild trust, build a sense of their own agency. And so really involving the people that you're working with in decision making. What would it look like to hear from the voices of individuals you are housing to inform policy and decision making at the agency and practice? Who really is making those policies, and where does their intention come from? Being curious. So spending our last 20 minutes together, again, emphasizing communication strategies, and I tried to pull a few things together that might be most helpful when engaging with someone from a harm reduction approach and generally engaging with someone in the work that we do. Communication is one of our strongest tools. The goal is to build trust, not control. And so this starts with how we talk and listen to the people that we're working with. Some of our foundational skills include active listening, motivational interviewing, de-escalating, using open-ended questions, practicing reflective listening. I remember, early on learning about reflective responding and practicing with people around me. And people might be confused and say, why are you talking to me like that? If that's not how you usually engage with them, or are you therapizing me? And so really being able to say, you know what, I'm just here practicing some of these skills because I want to be able to show up best for the people at my agency. Using affirming and non-stigmatizing language, and we'll talk a little bit about that. And again, that piece of offering information, not ultimatums, using that ask, tell, ask approach. Ask what this person already knows, tell them the information, and ask them to see what they think about it. What's their understanding? How does that sound to you? So when we use some of these strategies, we often refer to OARS. Is anyone familiar with the acronym OARS for engagement? Yes, some of the pieces of motivational interviewing. So we won't spend too long on some of these. Open-ended questions, affirmation, reflection, summary. Yes, we know this like the back of our hand. And so recognizing that we need to ask open-ended questions to open a door for conversation. It can be so important to affirm a person's change, no matter how small the change is. It can be so meaningful to reflect back what they're saying and then summarize for understanding and clarity. And so I want to take a moment to briefly practice some open-ended questions. I notice oftentimes individuals are frequently using more closed-ended questions, and of course, there's always a time and a place for closed-ended questions, but we really want to invite individuals to talk more and to elaborate. So sometimes this sounds like tell me more about or tell me about. Might start with a what or a how. I try to avoid why questions. Sometimes, personally, I think they come off as almost like an interrogation. Unlike those closed-ended questions that, again, are needed for demographics and oftentimes a simple yes or no. So instead of asking someone, do you use substances, you might explore with openness. Tell me a little bit about your substance use. So since many of us are familiar with this, I ask you to turn this into a more open-ended question. Are you worried about your substance use? How might that be a more open-ended and perhaps non-judgmental question? Yeah, tell me a little bit about your concerns regarding substance use. What worries you, about your substance use? Tell me about how your substance use affects your life currently. Yeah. Maybe even taking the worry out of it. Like, we might be worried about it, but are they worried about it? How do you feel about your substance use? What do you like about your substance use? What do you not like? Yes. Yes, I love doing, first and foremost, what do you like about drinking? What do you like about using X, Y, and Z substance? And it's a good place to engage someone because oftentimes no one's asked them, like, why do you like it? Tell me how using substances helps cope with life. Yeah, what does using substances do for you? And questions should always be used in addition to other conversational skills. Trying to ask one question at a time without rattling 5 in a row, that will definitely feel difficult to manage, might feel frustrating for the person, and they will likely respond to your last question asked or whatever they remember. The next piece is affirmations. So helping someone to affirm and recognize their strengths through a behaviorally specific lens. It is more than simply a positive affirmation. It is really acknowledging the behavior. So instead of saying good job, you might say you did a good job reaching out to your friend when you were experiencing a craving. Or, I'm so glad that you had someone to connect with when you notice that you were having the urge to drink. How might you improve this affirmation? You didn't drink today. You must feel so proud of yourself for avoiding drinking today. You succeeded or progressed in your goal to reduce or stop drinking. You acted outside of what feels normal for you. I hope you feel what a big deal that is. It takes a lot of resilience and dedications to stick to such a difficult goal. Nice work. Yeah, really focusing on that behavior and maybe connecting it back to a goal. Everyone needs some recognition. I noticed a comment about my pacing. I hope my pacing is okay. Feel free to provide any feedback regarding pacing and style here. So thank you for that. And all changes and small changes need recognition too. So keep that in mind. Reflections. This is such an important one because I, again, find that people often engage in a question back and forth. I try to think about using 2 reflections for every question. So really being able to paraphrase to help build understanding without parroting. So we don't want to mirror everything exactly this person is saying, but we do want to take some time to really digest their information. So the first is reflecting content. So you might say something like, it sounds like you've had a really hard day, or it sounds like fill in the blank, whatever that might be. Or I'm hearing that fill in the blank. If we are reflecting feeling, we might point out that feeling word. So you feel frustrated, you feel annoyed, you feel excited, you feel angry, whatever that is, and making sure that we're pretty close to either what they're telling us or what their body language is telling us. Reflecting meaning is much more of an interpretation. So you feel, let's say, disappointed because you ran into someone that you used to use substances with and it really triggered you. Or you feel, insert that feeling word because insert the context or content. Yeah, what I'm hearing you say, is that right? Like, help me understand. Again, coming from a curious place. Just want to make sure I'm hearing you correctly. What it sounds like you're saying is fill in the blank. And again, sometimes that doesn't come natural, but the more you practice it, the more natural it feels and people don't even realize. How would you reflect this statement? So someone you're working with says to you, I don't know if I can stop drinking by myself. So no questions, just reflections. How would you reflect back? It sounds like you need some support to quit drinking. It sounds like you want to stop drinking but don't know how. Sounds like you're in need of a support network. Wow, that sounds great. Maybe I can help. And maybe exploring, like, what is that ambivalence? I'm noticing and I'm hearing some ambivalence. What I'm hearing you say is that you could use some more support in changing your drinking habits. Is that right? How can I support you? You're feeling some ambivalence. What does this look like for you? And maybe following up with some questions. What might be a barrier? What does this look like for you? Awesome. So noticing how when we reflect back, especially let's say content, this person will likely talk more about the content. If we reflect feeling, they might talk more about the feeling. If we reflect meaning, they are going to give us more of an interpretive response about their lived experience. So keeping in mind how that moves the conversation forward or keeps the conversation stuck. And then the last part is summarizing, which I did not include a slide on, but keeping that in mind that you can use summarizing at any point, beginning, middle, or end of your conversations. One of the final pieces that I want to go through are recognizing and addressing stigma. We know that stigma isolates people, words matter, and so you can really be a powerful counterforce just by how you speak and model understanding, how you talk about the people at your supportive housing agency in front of them, behind closed doors, to other colleagues. All of that matters in addressing stigma. And so person-first language, we know, helps to maintain that environment of dignity, respect, and hope. So what is an example of person-first language? I think Washington knows better about person-first language than anyone. Yeah, recognizing this person as a person, not their diagnosis, not their behavior. Person who uses substances. And of course, each individual has the autonomy to identify how they choose, and we really want to respect that. But yes, we see the person first, often used to talk about people with disabilities or chronic medical conditions. Using terms like abuse, abuser, addict, alcoholic, user can be stigmatizing and negatively affect our perceptions about people with substance use disorders. You might say a person with a substance use disorder, a person in recovery, someone who uses substances. Instead of saying clean, especially when we think about our urinalysis, saying negative or not currently using substances. Instead of dirty, say positive or currently using substances. Person experiencing, yeah. Again, each person has the ability to identify how they choose. At the same time, we recognize that they are human first and foremost, and that their addiction is a part of them. At the same time, we again, once more, someone may prefer to identify as an addict or an alcoholic, and we want to respect the language that they use. Yeah, and noticing maybe some language is offensive. And so exploring that, and I'm curious what that form specifically included. Sometimes we just talk about substance use. Sometimes it's an introduction like, hey, I just have a couple of questions to you regarding some of your substance use behavior, or tell me a little bit about your substance use. I'm curious to know a little bit more about that form, but there's many different ways to broach a conversation respectfully and without, one, assuming that a person uses substances, two, judging them for using substances. So being able to, yeah, like, let's talk a little bit about some of your substance use. I do agree with the term substance abuse can carry some negative connotations and actually has been changed. Yep, I see the comment from Michelle. The DSM used to say substance abuse disorder or have a description for abuse, but now it's substance use disorder. So you'll see SUD. Again, it can just be simply substance use. Like, tell me a little bit about your substance use. What do you prefer? I like that idea too. And then, of course, we know that we need to respect and have our own boundaries and self-care limits while navigating some of these safety concerns. And recognizing through our supportive housing agency policies, when and how do I intervene if there's an imminent risk of harm to another resident, to staff, risk of overdose, violence, whatever that might be. Perhaps knowing and being trained on those de-escalation strategies. First and foremost, always preserving a person's dignity. And again, I recognize that sometimes there's so many challenges to implementing harm reduction at both a system or macro and a micro level. And maybe there are some terms or some ways to really practice that, even if not at the macro level, at the micro level. But there's, of course, staff shortage or burnout. Sometimes the community doesn't agree. And again, sometimes there's policy barriers or laws or regulations that criminalize possession and so on and so forth. So sometimes we know these policies might conflict with harm reduction principles and strategies like abstinence and eviction, things that we've talked about. But trying to create and reform policies, build alliances, adopt programs to reflect harm reduction, again, not only at the staff level, but how can this escalate into that macro level? Training is so important, and this is really only scratching the surface of harm reduction. Advocacy and education, get involved with larger organizations doing this meaningful work, whether at your state or national level, continuing to align with evidence-based practices. And creating a harm reduction culture ultimately means modeling this non-judgmental behavior. Again, how you talk to, about, with other people, about substance use, even on your days off, like what does it look like? How are you talking about substances? Aligning policies with harm reduction, having consistent language and training. Yeah, documentation, data are important for the system to see changes, including residents or individuals that you're working with in decision-making processes. What might it look like to have people with lived experiences informing the agency's policies? And last but not least, I want to recognize and really drive home that recovery is possible. How would you define recovery? And I'll give some examples. Recovery is a personal journey. Recovery is a process. Recovery is not linear. It absolutely looks different for everyone. It can be achieved through so many diverse pathways. Recovery for me might be different than recovery for you. Recovery for you might be different than the person next to you and the person you're working with. And so really taking the time to help this person identify what recovery looks like for them, because at its core, harm reduction is, again, meeting people where they are. And so taking some time to reflect on that, not only for yourself, but with the people that you work with. Sharing some resources here, you have access to that PowerPoint, harmreduction.org/resource-center. There is a harm reduction near you, more information. So check that out, as well as your local naloxone trainings, trauma-informed care guides. I've included some additional resources here for any and every kind of support group, of course, missing plenty, but here's a good list to start with. Last but not least, in our final moment before you go, would like you to take a moment to take out your device and scan this QR code, and please take a moment to complete the survey. It is anonymous, and we do welcome and appreciate your feedback. We hope to see you again in the future. I will go back to the resources again, and you actually have the PowerPoint. Emily just dropped it once more. These are some of my typical go-to recommendations. And then Emily just shared the evaluation link in the chat if you didn't get a chance to scan it. I want to thank you all for your time, attention, participation. Today's webinar was hosted by DBHR through the Washington State Healthcare Authority. Don't forget to check out FCS newsletter for all things FCS and upcoming training events. If you'd like more information on becoming an FCS provider, please reach out to WellPoint at the number here. Thank you all so much for your time, your engagement, your curiosity and compassion in the work that you do. Hope to see you all soon, and take good care.